Hello, everyone. Welcome to this UCL lunch hour lecture on medical leadership and gender disparities in India and England. My name is Kabir Sheikh, and I'm a professor of global health systems and policy at UCL's Global Business School for Health, and I'll be chairing today's lecture. It's my great honor and pleasure to introduce today's speakers, Dr. Julie Davies and Dr. Kamal Gulati. Now, let me start by introducing Julie before I hand over to her. Professor Julie Davies is director of UCL's MBA Health program in the Global Business School for Health and leads the two-week Global Health Challenge field visit to Saudi Arabia each January. Julie has published on medical leadership development in India based on a UCL AIMS Delhi research project and co-facilitated Chevening-funded workshops and mentoring for hospital physicians in Northern India with Dr. Kamal Gulati. She supervises PhD students in health management and planetary health. Her research interests include medical leadership development, health and climate change, equality, diversity and inclusion, micro-entrepreneurship, qualitative research methods, and management education. Julie has designed and delivered extensive education programs in China, East Africa, Kuwait, Russia, Singapore, and has a lot of distance learning experience as well. She's facilitated programs for business school deans globally. Julie, welcome to the lecture, and over to you.
Thank you very much for that introduction, Kabir. So thank you also to those joining us from different parts of the world and to our collaborators and participants that have been involved in this project. So Kamal and I would like to share with you our insights from our one-year project that's funded by the Strategic Partnership Fund of UCL AIMS New Delhi, which is looking at enabling medical leadership in India and England. We'd also like to thank Kirsten Ahmet, who's from the Faculty of Medical Leadership and Management Applied Directing there, who's worked very closely with us and collaborating on this program. So our key messages are to stress the importance of structured, inclusive medical leadership development across the life of physicians, from medical school to enable them to have sustainable careers. And the purpose of this is to enhance the quality of working life for physicians and obviously, of course, patient care. So we're going to look at various definitions of medical leadership, the drivers for our project, contextualize the challenges, talk about the methodology and theoretical frameworks we've used to make sense of the data, and propose a model. So Kamal will look at India, I'll look at England and some comparative analysis, and then we'll look forward to some Chevening-funded workshops in the new year in India, mentoring schemes and collaborations continuing jointly. So how do we define medical leadership? We see it as physicians doing institutional strategic work that influences beyond their narrow clinical patient care and delivery. And we see very much the importance of enhancing decent work for physicians, as well as enhancing patient care. So to date, most of the work on medical leadership development has looked at the Anglosphere, high-income countries, and shown that outcomes are positive from medical leadership development programs for individuals, organizations, and for clinical outcomes. And clearly, where there are sources of gender disparities, discrimination against women, that can be highly detrimental for physicians not gaining positions in the leadership hierarchy at senior levels, for women, services, medical services, inequalities, and for whole economies. So we're passionate about this project. As Kabir mentioned, I'm director of the MBA Health program at UCL. So we work closely with physicians and other clinicians in developing them. And some of them say they also have a kind of reading age of 5 when it comes to understanding business models, making business cases. So we're working closely, developing their leadership skills. This year, 2023, the NHS Workforce Plan has firmly put flexible and portfolio working on the agenda in terms of retention, but at grassroots level, that's not necessarily happening. We had the Messenger report last year about collaborative leadership, and we have this bizarre national graduate management trainee scheme in the UK, which is predominantly not for clinicians. And then we have very positive role models like Sir Patrick Vallance, who was in the medical school at UCL, who's one of these hybrid leaders that I think we look to create, who could lead in a medical school. He, during COVID, worked in the NHS as a practicing physician, but he's also head of drug discovery at GSK. And he worked in government with private equity and the task force for vaccines. So he can transcend multiple boundaries and sectors and speak languages that push transformational change in the workforce. More globally, post-COVID, we have the phenomena of quiet quitting, people quitting on the job, the COVID generation who didn't have the socialization skills during the pandemic, and the great resignation phenomenon where people are just quitting. And we know in the medical sector that's happening, people leaving the workforce altogether. And these awful statistics about sexual harassment and 7 to 8% of women consultants in orthopedic surgery. So there are real challenges there that need solid leaders and leadership. And Kamal will talk about the India scenario. So the literature too says there is a case to be made for engaging physicians in organizing and leading. It leads to better organizational performance, change management at all levels in the systems. In Cleveland Clinic, Ohio, James Stoller has given also very practical evidence of their medical leadership development programs, and Jason Geetz in Canada has done some reviews recently showing that there's little evidence base for some of these medical leadership program content, the curriculum, and also there is little in terms of longitudinal studies about the impacts on patient care. And certainly, obviously, for good governance, we need diverse boards, we need women at all levels. So I think what's interesting about our study, it's that post-COVID, during the pandemic, women, even without children, took on disproportionate levels of responsibilities in households. We know globally there's medical workforce shortages, and women do sometimes tend to offer to do jobs in the workforce that are not career enhancing. Medical students lost out on a lot of training and socialization and opportunities for their own development during the pandemic. And yet we also have extreme examples of other people working at home most of their time, not doing shift work and having quite different lives from physicians who are having to pay for childcare and commuting, with some exceptions like radiologists, some of whom I found work all the time at home. So there's lots of tensions in the system that need resolving by leadership teams and people who understand managing and organizing and inclusive cultures, gaps between medics and managers, and a lack of institutional support. We all know about the strikes in the UK and other parts of the world, the US, psychological distress, mental health and well-being, and physician burnout. So what can we do to re-engage, reimagine our physicians' sustainable careers? How can we reduce obstacles and enhance enablers? And the kind of national level policies that are supporting flexible working, why aren't they being necessarily agreed on the ground? Some people are being told that they're asking for part-time working is just a kiss of death for their careers. So our study is a qualitative study. We did a literature review on gender equality, organizational behavior. So the beauty of this project is having collaborators from medical school and business school. So predominantly we did 30 interviews in each country, one-to-one semi-structured qualitative interviews. We also did a survey in AIMS Jammu, and a case methodology looking at critical incidents, narrative accounts, thematic analysis and cross-country analysis. And along the way, we aired our findings with workshops and symposia, conferences, writing with MBA students, and blogs and so on. And then trying to conceptualize, we've written several papers, several in progress. We looked at the sociology of the professions, different occupational groups, forms of capital, optimal distinctiveness theory, in-groups, out-groups, and how they interact, and hybrids that move between the two. We wrote a Southeast Asia Lancet regional health paper using Joan Acker's notion of inequality regimes. So despite changing policies, we have still persistent gender inequalities because of systems. We're also looking at tokenism and intersectional inequality, women on women misogyny, there are elements of that, and looking also how we can collect data to mainstream reporting, gender equality reporting. In conceptualizing our data, we were also quite struck by the 2023 Nobel laureate for economics, Claudia Goldin's work on greedy jobs, which physicians have, jobs that eat you up or consuming, and her work on parental norms and how flexibility can reduce gender pay gaps. In addition, we looked at HROB literature on diversity management, looking at relationships between different levels of approaches to leading on diversity and inclusion. We've also done a paper on the resource-based view of the firm, so looking at organizational resources that support leadership amongst physicians, looking at the individual level of jobs and how demands exceed resources, and individuals' conservation of resources linked to work-life balance, quiet quitting, and burnout, and career resourcing over the lifespan. And then obviously management learning, kind of my background as well on that, strategic leadership, making sense in the workplace. So I guess we all know endemic reasons for gender inequalities in society. Women are seen as primary carers. Tanya Jenkins has looked at this kind of 1950s model of the Johns Hopkins residency white male trainee from a privileged background who has nothing else to do other than work on these relentless rotas, which is not fit for purpose in the 21st century. He also looked at grey literature, International Labour Organization principles on diversity and inclusion, which stress the importance of prioritizing diversity and inclusion in strategy and in culture within the composition of top management teams, holding people, line managers, senior leaders to account as role models, and making sure these actions are not just at the early stages, like we're having more medical students who are women globally coming into the profession, but also we have to look at promotions and development and access to opportunities. This Chartered Institute of Personnel and Development paper also stresses a systemic approach to inclusion, the importance of culture, supporting people to feel safe, going beyond mere legal compliance, and consistently being flexible and customized in being equitable. So our key messages, we need to look at the macro country level policies, what's happening within organizations, particularly medical schools and hospitals, healthcare organizations, and what's happening at the line management level to support individuals over their careers. And then finally, for my slide here, we've come up with this model of looking at the antecedents to inclusive medical leadership development, top-level commitment, boardroom commitment, line managers who are accountable, a whole career approach, evidence-based medical leadership development, various processes that will enable that, and then the outcomes of producing these kind of hybrid leaders and supporting these key sustainable development goals, 3, 5, and 8, which are focused on healthcare, equity, equality, and decent working lives, and collecting case studies to help us reimagine medical leadership careers in a very changing context of AI and robotics and new roles. Okay, so I'll hand over now to Kabir and Kamal.
Thank you, Julie. That was really great to see some of the methodologies being laid out and also the different frameworks you're using to address a topic which is really quite multifaceted and requires that kind of diversity, heterogeneity of approaches to look at. So that's brilliant. We already have some interesting questions coming through, and it just reminded me that actually I've I should remind participants about how they can ask questions in case they're not aware already. And so there will be time at the end. So please submit your questions at any point during Julie's and Kamal's talks. You can go to sli.do, sli.do. If you enter that into your internet browser and enter the event code, #medical, and you will get access to the questions. So now it's time for Kamal's talk. Dr. Kamal Gulati is Senior Scientist at the All India Institute of Medical Sciences, New Delhi, an honorary lecturer at the UCL Global Business School for Health. His areas of research interest include medical leadership development, project management, medical education, and health services research. He's received many awards, including the Chevening Research, Science, and Innovation Leadership Fellowship, University of Oxford, and the International Fellowship of the Institute of Advanced Studies at Warwick University, and also the Zon MW Fellowship at Erasmus University and the BDT Wellcome Trust International Research Management Award. Welcome, Kamal, and over to you for your talk.
Thank you, Kabir, and thank you, Julie. Julie, thank you for setting the stage. Medical leadership, the Indian scenario, it is interesting to see that mostly the research work is being carried out in the high income countries, and not much work is being done in the low and middle income countries when we talk about the medical leadership. So when I do research in the area of medical leadership, and I tell people, my colleagues, that my area of research interest is medical leadership, sometimes they give me a strange look that what is medical leadership, so in our part of world, we are more focused on the communicable diseases and non-communicable diseases, and health systems strengthening, particularly medical leadership, is not a priority research area when we go at the institute level or at the policy level. Next, please. So a brief overview about the healthcare industry in India. India is now the world's most populous country with a population of about 1.4 billion people. And likewise, our healthcare market is also quite huge, about US dollar 372 billion. And healthcare is one of the largest employers in India, as it employs about 4.7 million people. So this demand poses challenges as well as some opportunities. And interestingly, our public expenditure on healthcare is very low compared to OECD countries and other neighboring countries. India spends around 2.1% of its GDP on the healthcare when it comes to public expenditure. We also struggle with the trained manpower, particularly trained medical professionals. And India is currently undergoing national public health reforms through two very ambitious government schemes of Pradhan Mantri Swasthya Seva Suraksha Yojana, that is PM scheme for social security, and the other is ABPMJ, that is the National Insurance Security Scheme for the poor people in the country. Next, please. So it is just a brief overview of the Indian healthcare system. Our healthcare is quite diverse and dynamic. We have public sector hospitals which are managed and funded by Ministry of Health and Family Welfare. Again, we have distribution at state and central level, then rural areas and urban areas, right from community health centers to public health centers. We have hospitals which are managed by Ministry of Defense, Ministry of Railways. Then we have private hospitals which are for profit, and majorly the demand for medical services is in the urban areas is provided by the private sector hospitals. Reason being that they are more accessible, as well as the quality is better than the public sector hospitals. Next, please. So now, if we talk about the medical leadership, the National Health Policy 2017, which is drafted by the Ministry of Health and Family Welfare, Government of India, gives us the national mandate to invest into leadership skills building in our healthcare system. So this policy document is very, very important because it is for the first time that the Government of India recognizes the need for investing into leadership capacity building in our healthcare system. So health system strengthening is like one of the objectives of this policy through medical leadership. And this is why it is an important and interesting mandate to us working in the area of healthcare leadership. Next, please. The next policy document which I would like to share is a Vision 2035. It's a white paper of Niti Aayog. Niti Aayog is Planning Commission of India, which is chaired by the Prime Minister. It also gives us the mandate to invest into managerial leadership at the national and state level. Next, please. Now, if we talk about the medical leadership scenario in India, traditionally, like many other low and middle income countries and possibly many Western countries, medical school culture has not encouraged interest in business education. And there are many reasons for that. And developing leadership capacity has not been a priority area in the medical schools. Formal management training is not compulsory when our consultant level physicians take the leadership positions in their respective organizations. And doctors, particularly in the public sector hospitals, are generally promoted by virtue of their seniority or rotation. So length of service is considered as the main criteria when one reaches to the leadership roles like a director, medical superintendent, or deans of the medical colleges. And generally, they are not provided any management training before getting these roles. And surprisingly or unsurprisingly, many clinicians consider themselves as accidental leaders or leaders by chance. So therefore, we believe that the leadership crisis exists in our medical profession, and the reasons or the responsibility possibly rests with the regulatory bodies or the policymakers who did not focus much on leadership development in our country. Serious efforts possibly not made to develop leadership in our system, and if we believe that if doctors need to bring reform, they need to be involved in the leadership or management roles from an early age, right from undergraduate level, like it is defined in the NHS Medical Leadership Competency Framework, which gives us the direction about the undergraduate, postgraduate, and consultant level training when it comes to medical leadership. We conducted a first study from India, which highlighted that the significant leadership competency gaps exist in our healthcare system. It was published in some international journals. And there was a huge demand, like about 95% of our study participants. The total number of participants was 540. So 95% of our participants indicated a need or desire to attend leadership development program, and we conducted an off-site residential leadership development program, which was attended by 96 physicians, both from public and private sector hospitals. And using the NHS Medical Leadership Competency Framework, our survey questionnaire, we did the pre and post assessment and assessed the 30 medical leadership competencies pre and post the program. And we found that medical leadership development program can be an effective resource when it comes to developing leadership capacity in our part of world. Next, please. So now the question is that why the medical leadership has not progressed, or why it is difficult to develop leadership competency in our healthcare system. So the whatever responses we have got or whatever conversation we had, it looks like that the creating dedicated time for leadership training and education in an already tight medical curricula, both at the UG and PG level, poses a great challenge. And those who are at the consultant level doctors, they are worried that their involvement in management roles will drift away them from the patient care and also limit opportunities to pursue their research and academic ambitions. Further, in the public sector, particularly the hierarchical structure of medicine, linking of promotion to the length of services and the specialization also discourage doctors from being involved in leadership roles. And most importantly, I believe that the medical leadership has not yet been recognized as a distinct specialty, or there is no clear career pathway. So that can be a one challenge. And that is possibly the reason that the medical leadership competency gaps are existing in our system. And our national health programs are suffering because of this leadership competency gap. Next, please. And we have also shown in our research that in India, as per the available data, women take only 30% of doctors are women compared to 80% of nurses. But when it comes to leadership positions, that women comprise only 22% according to the Insiders Reports 2021. Next, please. Recently, this is the data analysis which is in progress, and we got this data from the AIMS. AIMS is like All India Institute of Medical Sciences, New Delhi, and we took this data from the annual reports right from 2004 to 2023. And we try to look at that what is the gender distribution when it comes to The consultants at the department head level over the years, right from 2004 to 2023, and we found that it is mainly male dominated when it comes to occupying leadership roles like head of the departments across different specialities in clinical, paraclinical, and surgical disciplines. Next, please. The same is the scenario with the consultant level positions like assistant professor, associate professors, and professors levels right from 2004 to 23. It is again male dominated. The women are like numbers are rising, but I think it will take a long time to reach the gender equality in our institute. Next, please. This is an interesting report, which is All India Survey of Ministry of Education. It shows that right from 2011-12 to 19-20, the female students have been almost like 60% when it comes to like undergraduate studies or the postgraduate studies. So it shows that while coming to medical education, majority are women, but when it comes to leadership roles, women are less, around 22%. Next, please. The same in the female students percentage is around 63 to 66% when it comes to medical courses. Next, please. Yeah, so we suggest some strategies based on our research about developing leadership in an Indian healthcare system. We believe that in contrast to West, India might first deliver LDPs for the senior doctors, those who are already in leadership roles. But these LDPs, leadership development programs, needs to be contextualized for India in terms of economic, workforce, and cultural challenges. State agencies like medical schools, business schools, and professional bodies need to be engaged and collaborate to conduct these programs. And there should be a commitment at all organization levels to achieve diversity, equity, and inclusion in medical leadership and to support leadership development. Next, please. So we call for collaboration of medicine and management, or basically medical schools and business schools, to conduct joint courses and programs, leadership development programs, also interdisciplinary workshops, faculty exchange program, like medical school faculty going to business schools or business schools faculty coming to medical schools to have an exposure or first-hand experience how both the systems work. Next, please. Also, we propose internship opportunities between business schools and medical schools, carrying out joint research projects like we are conducting with the University College London Global Business School for Health. Mentorship can also play a critical role while developing leadership capacity. Next, please. Collaborative case studies, adjunct faculty engagements, and the joint conferences can also be possible tools to for collaboration and bringing medicine and management together. Next, please. Now, this is interesting that our Union Health Minister, Dr. Mansukh Mandavia, during a meeting, he highlighted and encouraged representatives of all AIIMS. And I should tell you that there are 22 AIIMS-like institutes coming up across India. And he suggested that AIIMS-like institutes should also collaborate with Indian Institute of Management. Those are the business schools to bring management capacity to medical schools. So this is very important. So some noise is happening at the institute policy level. Next, please. So if I summarize that the national health policy gives us the national mandate to invest into leadership capacity building. There's a need for medicine management collaboration, both at national and international levels, to strengthen the evidence about medical leadership and design and conduct medical leadership development programs. We also need medical leadership models and frameworks like the NHS Medical Leadership Competency Framework in our part of world. And I think by that we can develop some effective leaders and drive entrepreneurship and improve healthcare management practices in healthcare industry in India. Next, please. So just to mention that recently on 22nd November, we had a UCL AIIMS strategic meeting in New Delhi, 23rd November in AIIMS New Delhi, which was attended by the leadership of AIIMS New Delhi and the UCL. And during this meeting, we had a good conversation about developing medical leadership and collaboration and knowledge exchange in this area. Next, please. Over to you, Julie.
Okay, thank you. So I guess in summary, in terms of gender disparities in India, it's a patriarchal society, particular expectations of women to marry early and to take care of in-laws. So it has differences, some differences from the UK. And the old boys network, and women feeling left out of the boardroom was a particular aspect in response to our research question. So this is the problem statement. As Kamal has said, most hospitals are actually led by men, physicians. They're a bit different from the UK, where actually there are many non-physicians leading hospitals, but they don't have medical leadership training. And we looked at the kind of Cleveland Clinic, the US model of the MD MBA. So Cleveland Clinic London is run by a medic who has a GMC registration and also an MBA, and is president of Cleveland Clinic London. So particularly we were looking at the drivers and the obstacles for development in both countries, with a particular focus on women and inequalities. And as I mentioned earlier, we've blogged our way through this project, trying to raise awareness of the challenges, covert and overt, in both countries. So there are particular statistics about women in India. Only 14.2% of medical doctors, according to 2022 WHO data, were medics. And Karen and colleagues found that many had actually left. So those who'd actually gone through the training were engaged. 20% of 30 to 40-year-olds were actually working at home instead. And there has only ever been one woman director of AIIMS New Delhi, one of the most prestigious medical schools, or the most prestigious in India. And of the new AIIMS, only 3 out of the 18 new directors. So the profile here is of the interviewees in India. Various quotes. We categorize these at macro, meso, and individual levels. So, relentless stream of patients, huge unmet needs, lack of institutional support, invisible administration, and physicians not feeling that they could be engaged in decision-making to improve patient outcomes, and men dominating the boardroom. We also saw positive comments about systems level changes, a huge appetite for leadership development, positive comments from men about women being polymaths and multitaskers and natural born leaders, and opportunities people saw for developing skills, particularly procurement was an issue, legal issues, emotional intelligence, conflict management, mentoring, dealing with criticism, stakeholder engagement. And at an individual level, there was recognition that despite a preference for male doctors in communities, that women were more open about their health and well-being with women physicians. And since COVID, everyone wanting more time, more work-life balance. So we've summarized the key themes that emerge from India here, the sample, and prioritize the importance of medical schools in this ecosystem, continuous medical leadership development, somehow within giving bandwidth and space for women to have some work-life balance with flexibility, and as Kamal has just done, collecting more data to show inequalities and scope for improvement. So I'd just like to wrap up looking at the English sample. We had a range of people. We had a very interesting medical school student who's 21, who's actually already had 3 years boardroom experience as a youth representative on an integrated care board. And we had people also towards the end of their careers. 5 women were working in the private sector. 2 women consultants had always, since they'd had kids, working part-time. I had quite a lot of surgeons in my sample, and we also had quite a few people compared with the India sample who had MBAs or were working towards MBAs, and over half had Asian backgrounds. So if we look at the latest GMC data, you might think there's a very positive story happening here, because we we have more than actual gender parity in Scotland and Northern Ireland. There are more women doctors there than the men doctors. And in England, it's 49% registered licensed female doctors. 52% of new doctors are women. There are more women joining, and there are more men leaving the profession. It's interesting that actually 52% of international medical graduates are men, and there's a growing number of overseas trained doctors joining the workforce, and also increasingly part-time working and flexible working. However, this can have potentially negative effects on women's careers in terms of hierarchies. And there have been developments. Sally Davis is a great advocate of Athena Swan to increase the number of women deans in medical schools as well. So as Kamal says, we have this quite old now NHS medical leadership competency framework. And we've had various reviews, and the GMC itself in its latest report emphasized the importance of good leaders who can provide personalized support for the well-being of healthcare workers. But still, we have the challenges of persistent gender disparity, particularly amongst surgeons, and issues of harassment not being tackled. So Steve Powis, who I discovered this morning, is coming on the trade mission that I'm joining next week in India. He's the National Medical Director of NHS England. He was giving evidence a few weeks ago in the House of Commons, and he made this point. So he admitted that he had no structured leadership development himself when he was going through the system, and he was very hopeful that things would be different in future. And he cited the FMLM program for National Medical Directors Clinical Fellowship Scheme. He also emphasized the importance of leaders, physician leaders, as role models, developing a culture where people could speak up and felt supported and set the right tone. However, our data kind of contradicts some of his perhaps assumptions that medical leadership development is widespread and freely available and funded. And particularly there are, as we've mentioned, challenges for women all over the world, including childcare access, affordability, the motherhood penalty, physicians who are dual income couples, particularly in the UK, when they're training, having to move potentially every 6 months as part of their traineeships. And with children in school, that can be very difficult. Something has to give. And particularly, I guess, galling is when you see other professionals who are working increasingly at home. So some of the comments from the interviewees emphasize that the old boys' school network is still there. Unlike their bosses, they can't afford to buy homes. It's not worth being a physician any longer because of the cost of living and the conditions. Being a slave to rotas, rota fodder is a challenge. And although official policy says part-time is, particularly encouraged, in practice, it's strongly discouraged. There's also a leaky pipeline with women joining the profession and then not rising in the ranks. And one very senior woman said she was interviewing for a very senior position, and the men just had on their CV evidence from the boardroom, very strong evidence of their leadership activities, where the women didn't seem to have garnered that. Positive comments we found examples of, we've had finally a female president of the British Orthopaedics Association, the Royal College of Surgeons. People are seeing the old boys club being dismantled, more parental leave, better conditions in the NHS in terms of family-friendly policies and other sectors such as financial services. Greater openness in reporting misconduct, particularly after the Lucy Letby scandal. Younger people have more positive views of women leaders and more mentorship available. Generation Z just not tolerating this kind of always working phenomenon. and women doctors joining entrepreneurship courses, GPs taking on leadership roles in primary care networks, although not necessarily chairing them, and people saying they've had lots of support throughout their careers, and particularly graduates of our MBA health program saying it's given them a real confidence boost. And I have one of my graduates who's leading now a new service stream for women only in private healthcare. Yet we see still lots of intersectional inequalities, physicians who stepped up during COVID being forced to step back, as I said earlier, to clear backlogs. So lots of reasons still to drive reducing intersectional inequalities and reducing, in practice, discrimination. Opportunities to provide greater psychological safety. And what we're doing next is looking at papers that compare and contrast the two countries, driving and restraining forces in both India and the UK, looking at societal norms, commonalities. For instance, there are positives, I guess, in India of greater domestic help. In the UK, people are finding some of their partners are working from home more, which actually makes their lives easier. But this constant challenge of these greedy jobs that lead to burnout potentially, unless there are kind of interventions to support people in these jobs. We're also looking at possible solutions and talking, particularly some of my MBA health students are saying, where can we go in India? You know, is it Bollywood? Is it ex-cricketers, senior medical leaders who can really change the patriarchy and move forward the agenda that we're trying to advance? So definitely we found an appetite for medical leadership development, an appreciation that physicians need support. Organizations need better quality leaders, multidisciplinary teams, collective leadership. And we know that diversity management poorly executed has very negative effects at the team level for patient care, for nations and their productivity. There was an article in Economist last week about governance and the importance of women in governance. So we've seen some very good examples. We're collecting positive examples of equity in the workforce, and looking at medical leadership interventions that are evidence-based and that can support inclusive cultures. So in summary, really, we're adopting this multi-level approach of what's happening at the macro policy, national level, how we can join that up with what's happening within organizations, and how we can support individuals too. And then finally, going forward, our plans for the new year are to continue this joint working to involve more physicians in India and physicians in the UK actually talking together and jointly discussing their issues. So this BBC Radio 4 listening project is a model of dyads, of couples, of counterparts talking about their challenges. We've worked with Jane Dacre at UCL, whose Medical Women Talking podcast is excellent. We'd like to replicate that with physicians in India and the UK. We have chevening funding for workshops in January and February in India. We're working on papers, potential book, and with colleagues at Warwick, particularly on orthopedic surgery. And I guess there are elections in both countries next year, so it's interesting to see how the landscape is changing. And hopefully we can make a difference, make more impact with our research and our project. And in tune with the 2030 India-UK Future Relations Roadmap, support these various sustainable development goals for healthy lives, for the healthcare workforce, for physicians, gender equity, equality, decent work, and reducing inequalities. Okay, so thank you very much. I'll stop sharing now and hand back to Kabir.
Julia and Kamal, thank you for that very sweeping presentation, covering really a range of themes. Very interestingly, not only addressing some of the thematics and data around medical leadership, but also addressing important questions of the context, cultural context, governance, and highlighting some positive examples as well. And we've got great engagement already in the Q&A. So there's some questions on methodology, some questions on the underlying precepts and concepts. So I'm going to curate them a little bit. Let's start with one which is quite fundamental, and maybe you have an answer for. And that's why are we focusing on medical leadership? For comprehensive health services and certainly public health planning, we need to engage other healthcare providers as leaders as well. So that's something chunky to bite into. Over.
Okay. Kamal, would you like to start? You've been at this longer than I have.
Yeah, it's an interesting question, and I have seen similar questions in my institute also, when people say that why should we invest into medical leadership when we have other challenges which are directly related to our patient care and all that. But I say that somewhere we have to start. We have to focus at some point at some focus areas. So we have chosen this area, and it is an already established area in the Western context. So we are trying to do similar kind of work in the non-Western context, and I think there's a growing evidence which suggests that leadership has a direct correlation when it comes to improved quality healthcare delivery or clinical outcomes. So that excites me when it comes to medical leadership. Julie may add, please.
Yeah, we're certainly not, we really don't envisage the ideal of these leadership development programs being just medics. I mean, the model here is integrated care, multidisciplinary teams, collective leadership. So Dave Probert, CEO of UCLH, gave an induction talk for us and said the ideal is actually a triumvirate. You know, you have CEOs, maybe administrators like him, who are non-physicians, working with a physician and other allied healthcare professionals. So they're very impressive, you know, nurse CEOs and social science CEOs. So I see this as a collective endeavor, and we have physios, we have nurses on our MBA health program. But I think there is a particular gap, the intensity and the length of the medical school curriculum beyond the GP training, 11 or however many years to be an orthopedic surgeon, and then having no leadership. I think one of my relatives who's an orthopedic surgeon said he just had half a day's leadership development before he applied for a consulting job, which is not really enough. So yeah, we're taking a spotlight on medical leadership, but we don't think physicians should be isolated.
Thank you, Julie and Kamal. So I think the point is made about medical leadership being an entry point, but you also recognize the importance of the different healthcare professions and developing those as well in a broader context. I think there are two more questions which are quite similar and speak to a similar theme around cultural reasons and barriers and how one might seek to overcome them. So I'm going to read them both out, but feel free to choose one or to answer both of them. So the first one is, how do we handle the cultural reasons and barriers that reduce the participation of women in leadership in India? And the second question that is related is, how can your findings actually influence systems changes in a patriarchy and in a context of conservative profession? Okay, over to you.
Yeah, when it comes to like Indian
first?
context, yes, India is a patriarchal society and male dominated, both at social system as well as in the boardrooms. And we have enough evidence to support this statement. But if you see now in the modern India, the time is changing. Women are more empowered, and men are also like adjusting to the schedule of women, particularly in metropolitan cities where the women are working. But yes, it makes a lot of sense when we say that the primary responsibility to manage the healthcare, hospitals or work and family is majorly taken by the women, and they find it challenging to balance work and professional lives. When it comes to our findings, the idea is to generate evidence, because what we are saying right now is not evidence based, or it has been like hypothetically we used to say. But the idea is to first generate first hand evidence when it comes to medical leadership or women in medical leadership, and then once we have the evidence based on data, possibly we can approach the policymakers both at organizational level as well as systems level, and we can influence them to make some adjustments or changes in the existing system. But right now the idea is to generate evidence.
Yes, I agree. A patriarchy. And when we've had these lunar landings, Modi celebrating women, the G20, the W20, distinct focus on women recently. But yeah, as an outsider, I can't influence the impact the Indian medical system. So some of our students actually who were born in India and have a background are happy to work with us in some of these workshops. And I think it's political will. That is a very good question. As you know, Kabir, yourself, how do you tip the balance? If more women are coming through medical schools, one would hope there'll be a critical mass at some point.
Thanks, Julie and Kamal. So the next question is similar, but it kind of overturns the conversation in a slightly different direction. It's a three-pronged question, and speaks a little bit to the experience of the questioner as well. So many companies in my industry, which is engineering, so the questioner is saying they're from an engineering background, are putting significant resource and effort into recruiting and retaining female engineers. However, my partner works for the NHS, where approximately 80% of the workforce is female. However, no efforts are being made to recruit more male staff to address the gender disparity. Why is there only a focus? So that's the background. Why is there only a focus on addressing gender disparities in senior roles, but not across the workforce? Okay, over to you, Julie.
Yes, I remember going to a French school of engineering, École de Mines, and asking about how many women they had. And they said Shell and other people were killing themselves to get their women graduates, because once you had women, mixed, the men behaved so much better. So yeah, I agree. And there's this you need to, where there is a shortage of men. I mean, we have an issue in the UCL, Athena Swan, silver or gold for one of our institutes, women's health, and they don't have enough men on the program. So they are shifting their gender equality goals to attract more men on their programs. There's this WHO report delivered by women and led by men, so that 75% of healthcare is delivered by women, but you don't see them in the boardroom. So clearly we are advocating more women in senior leadership positions. But I think it's equally unhealthy to have 80% women and no men in these NHS leadership positions too, because if we have diversity in the population, people want to see themselves represented in the workforce. So too many women is not a good thing either. So we need fair representation. That's what we're arguing for.
Thank you, Julie, and thank you also for referencing that WHO report. And I think it's really quite striking how the differences, the disparities play out at different levels, and that's also a reflection of how gender plays out within systems. So there are two questions now. We do have a little bit of time left, and you've been very concise and to the point in answering, so that's allowed us to squeeze in more questions. So there's a couple of questions now which speak a little bit to issues around positionality and methodology, which I think you might find interesting. So I'm going to ask both of them. Okay, feel free to pick one or to answer both. The first is, what are your own positions as researchers, and how do you reduce bias in your study? And the second question is, how do you engage very busy professionals in the study? Both certainly things that I've experienced. So looking forward to hearing your insights.
Come on.
Yeah, it's an interesting question, and it reminds me when I was giving my final viva of my doctoral research, and my response rate in a quantitative study was 54%, and it was again on medical leadership. The same question was asked, that how your response rate can be 54%. It's quite high, and how could you manage to approach very busy medical professionals while collecting your data of 540 doctors across India? So I'll say yes, bias is of course there, because we use the purposive sampling or the convenience sampling, and we approached medical doctors, those who are in my network, being in AIMS. We collected data from two public hospitals, one being AIMS New Delhi and one in AIMS Jammu. Majority of our study participants are senior medical doctors, both men and women, from my personal network or by reference. So yes, that can be one reason to approach and having consent to participate in our study. Julie?
Yeah, I too had a convenient sample. So you're speaking sometimes to the converted. People who are applying for MBAs already have one. So that does have a bias. Neither of us are medics, so I guess that, and I have a social science background. So yes, inevitably we're honest about our potential bias, and we, you know, we're many people from Metropolitan as well, many people from London I interviewed, and Delhi with the other sample, also Jammu. And we did try to find counterfactuals and cynics and people who are maybe anti-management and leadership too. And I think, as I mentioned earlier, the airing, having workshops, writing publicly about this, getting feedback, talking to people who've written a case study as well, opening up our findings and letting people criticize our sources. Hopefully that's reduced the potential for bias.
Great. And in the interest of time, I think I'm going to try and wrap up, but I'm going to keep my wrap up short because actually we have another few more questions coming up. And I'd rather you answer those questions. It's a very, you really touched upon the surface of a number of things and initiated inquiry into this area, which is very underserved. And I think it would be great if some of the people who have questions could follow up with you offline and continue those conversations. But I'm going to leave you with one last question, which is, how do race, ethnicity, and caste play out in your studies? And maybe if you could respond as briefly as possible, and then we will try and close in time. Over.
Again, talking about the Indian context, we have not considered caste or religion in our study. It was purely based on the position of the person, gender, age, work experience, and how much time they dedicate to management functions on a routine day. So we did not consider caste and religion or ethnicity in our study.
Yeah, and my sample, more than half were from ethnic minorities, and certainly a mix of religions, Muslim, Hindu, Christian. So intersectionality is kind of included.
Thank you. So maybe that's a further area of inquiry, because certainly I know that affirmative action, for example, is a big point of contestation in the Indian context, and it is elsewhere as well. And it would be great to understand the role that some of these factors play as well. So we are almost at time. So I have just a minute to thank everybody for their participation. Thank the audience, but also especially Julie and Kamal for their rather masterful talks. I was really learned a lot in this very short duration and really opened up a whole new area. But also Diana, Kate, and the technical team have been responsible for setting this up and publicizing it these past few weeks and making this event happen. So the next lunch hour lecture will be on 5th of December, and it's by Dr. Victoria Garfield. And the topic is, can good sleep help our brain as we age? So if you get a chance to put that into your calendar, then that as well. And I'll close here with thanks to all of you again. Bye-bye.
Thank you, Kabir. Thank you, Julie. Bye bye.
Thank you very much.